It's great to be here today. We want to highlight, because there's so much information, but two very timely issues, marijuana and opioids. I have nothing to disclose. I want to be able to cover for you in a short period of time what I think the pediatric provider community needs to understand about the unintended consequences about marijuana exposure to the pediatric population involving pregnancy and breastfeeding, unintentional exposures, and adolescent use. This map shows the state, the United States, in terms of where it's legal to use marijuana. The dark green are recreational marijuana laws have been passed. This is as of November 2016. And the light green are where medical marijuana laws have been passed. And you can see that Utah is pretty much surrounded by states where it's legal. And astoundingly, 60% of the United States population live in a state where some form of legalization is present. This is extremely important here in Utah because of what's happening right now. There is a very vigorous effort to place a ballot initiative on November 2018 ballot to legalize medical marijuana in the state of Utah. We don't have time to go through the ballot right now. It's actually the initiative is very long, and I urge you all to research it, to read it, to know, before you sign any petition, to know what it actually says. It's a very broad law. It would change other laws that we have here in Utah, but it is heavily funded to get passed, and so they're hiring people to go out and do the signatures. So this is going to be a major topic of debate over the next year. The health issues regarding increased availability of marijuana are being published over and over again. This chart is in Oregon. The number of cannabis-related ED visits to a 4 hospital system jumped when they were even just debating whether to pass a measure to legalize marijuana, and then jumped even more significantly when the retail shops opened. These are adults presenting. The reason that they're presenting is that the users are being surprised by the potency of marijuana that's available today. An Oregon doctor from their Poison Control Center commented the middle-aged or older individuals who had tried marijuana in their youth decided to light up again only to find today's pot is so much stronger than the weed of their college days. Soon they're sweaty, they're anxious, their hearts are racing, and they're hallucinating, and they're calling the ED. Or showing up in the ED about that. So the other issue that we have regarding especially medical marijuana is no one knows anything about a dose of medical marijuana. And even when it comes in edibles, serving size issues prevail. Colorado and Washington both say that a serving size of THC, which is what they measure, is 10 milligrams. But a candy bar infused with marijuana can contain up to 50 milligrams or more. So that means you're supposed to just take one bite of your candy bar, and that's your serving size. Quality assurance is unknown because it's not an FDA-regulated drug. There is no institution that verifies what they say on the label is in there versus not. And the plant variability is quite wide. There are hybrids now of marijuana with very high potency of THC available. And that is one of those unknowns when anyone is prescribing medical marijuana for use. On to the pediatric effects. The federal government still reports that marijuana is the most common illicit drug used by pregnant women. Remember, from the federal standpoint, marijuana is still an illegal drug. There is surprisingly little information, however, on the physiologic effect of cannabis in pregnancy on the mother. Additionally, most of the data reflect cannabis administered by smoking. There's no data about a mother who is now taking edibles during her pregnancy and how much THC she's exposing her fetus to. And again, even if she's smoking, there's no studies out there now of the higher potency THC marijuana that's being used. We do know that THC crosses the placenta and can affect fetal development. Smoking cannabis during pregnancy is linked to lower birth weight in the offspring and increased risk of NICU admission. There's been no association, though, associated with congenital anomalies, and there's no phenotypic withdrawal syndrome or newborn syndrome associated with marijuana use. But it does affect the growing fetus. It also distributes to breast milk, and it distributes to breast milk in a much higher concentration than the mother's serum because THC is highly lipophilic. Well, how I classify THC is that it works on the neurotransmitters in our brain, just like any other substance of abuse. That's why they become substances of abuse, because they alter the concentration of the naturally occurring neurotransmitters in the fetal brain. And those neurotransmitters are there in the fetal brain to help direct the correct cytoarchitecture development of the fetal brain. So I think we should be classifying marijuana exposure as the same that we classify methamphetamine exposure, cocaine exposure, because they are all work on the central nervous system. And that what we know is, like as with all substances of abuse, there are long-term studies showing that associate prenatal marijuana use to common neurobehavioral and cognitive outcomes in children, including symptoms of ADHD, increased externalizing behavior, decreased cognitive function, and deficits in learning and memory tasks. We desperately need more studies to assess the outcome of the heavier marijuana exposure on children. Because of this, the AAP and ACOG both discourage the use of marijuana during pregnancy, preconception, and lactation. Another way that is increasingly being published is unintentional exposures is through pediatric ingestions. This graph is based on data from the National Poison Control Data System from 2000 and 2013. What they did is they looked at the states that were in transition, so they had just passed or they had passed medical marijuana laws. And the bar in the middle shows the year that the legislation got passed. And you can see in the dark bars that the rate of marijuana exposures among children less than 6 years of age dramatically increased. The mean age of the child was 1.8 years. Most of the exposures were classified as unintentional, and 83% occurred in the child's own residence. Ingestion was the most common route of exposure for 3/4 of those exposures. Almost half of those exposures were cared for in a healthcare facility. 1/3 were treated and released. 11% admitted to a non-ICU setting, and 7% to an ICU. Colorado has a champion there that is very concerned about the unintentional consequences, Dr. Sam Wang at the University of Colorado. And this is part of the Colorado experience. This graph shows the annual children's hospital visits and regional poison control cases of unintentional marijuana exposures in children 9 years or younger between 2009 and 2015. 48% were from infused edibles. And the authors definitely surmise that the legislation did affect the number of exposures in their state. Dr. Wang's also published some case reports about children that are exposed. In the first one, the age range was 10 months to 4 years. They were all male. All presented to the ED with abnormal neurologic physical exams of lethargy and somnolence. One had bradycardia. They all received extensive workups, remembering it's a small child that's somnolent and lethargic. So they got blood work, lumbar punctures, had CT scans, and x-rays. All were positive for THC in the urine. 4 of the 5 had household members with confirmed medical marijuana cards. In the second study of those 14, again, the family was the source in most cases. Sometimes it was the grandparents. 2 of those children were admitted to the PICU because of their level of somnolence and their level of respiratory depression, and they all received extensive workups. In Utah, these are scenes from the Utah Poison Control Center database, is you could see that in 2014 and 2015, an increased number of calls to the poison control regarding marijuana exposure. Still, the vast majority in Utah are about an adult getting exposed and concerned about their level of what just happened to me. But you can see that the green is the age group of 13 to 19 years, so teenagers, and then a significant number of children less than 7 being the Poison Control Center being called about their exposures. And the headline, 6th grader brings pot brownies to school, and all of the students got sick because they ate some of the brownie. That happened here in an elementary school last year in September of 2016. So even though we don't have legalized marijuana, it is in the state, and children are getting exposed. And is it any wonder that toddlers are the main group that are getting exposed? These are images of one side is an infused product with cannabis and another side is not. And none of us could tell the difference, and toddlers certainly can't. This is what's available in some of the dispensaries. You can celebrate Easter with an infused chocolate bunny. You can buy soda pop that has THC in it. You can buy candy bars that kind of look like what's available, the uninfused kind. There's a lot of humor involved with changing the names of the candy bars. And this image was published in the Colorado newspaper, challenging the readers to tell which one is an infused product with cannabis and which one is not. So a study that was an analysis of the National Poison Data System, they looked at calls received between January 2013 and December 2015, this is nationwide, that involved marijuana brownies, candies, cookies, beverages, or other foods. Colorado and Washington yielded the highest number of exposures. The number of calls increased every year of the study as more and more of these products are in the community. The most common age groups were 5 years or younger and between 13 and 19 years of age. The most frequent clinical effects were drowsiness and lethargy, fast heart rate, agitation, irritability, and confusion. No deaths were reported. These studies demonstrate that the increased availability of marijuana edibles has unintentional consequences. It's not only children, adults are also impacted by the challenges. Part of it is because of the potency. Part of it is because the pharmacokinetics of the edibles is that it may take 30 to 90 minutes after you eat that one bite of a chocolate bar for you to start feeling the effects. But if you're a little impatient and you've only waited 30 minutes and you're not feeling anything, you may have 2 or 3 more bites, but then in 2 more hours, you've had now 30 milligrams of THC or 50 milligrams of THC. And I think that's probably why they call the emergency department as an adult. And the same thing would happen with children too, and gets them into trouble quickly. One thing our state would have to deal with if we had a medical marijuana law here is making sure that there's child, quote, resistant, unquote, packaging. Colorado had to write a law after legalization to make that happen. Do you also do the same child-resistant packaging for the recreational products versus the medical products? And rules for this vary by state because, again, federally, it's still an illegal drug, a legal substance. Another way, but less common, is that children get exposed is through secondhand smoke. Smoking marijuana is still the most common way that adults use marijuana. There's over 60 phytocannabinoids in marijuana and other compounds that I list here. Studies in a smoking chamber show that non-smokers can test positive for THC. Another study that showed healthy volunteers who were not marijuana smokers, but volunteered to spend 3 hours in a Dutch cafe where it was legal to smoke marijuana, and then they came out and had their saliva tested. They all tested positive for THC and cannabidiol in their saliva. And there is a case report in the Child Abuse and Neglect Journal in 2012 of a 13-month-old infant who presented with apathy, unresponsiveness, and loss of appetite after sleeping in a room where 20 cannabis users were having a party. So there is evidence that that's another way that children can get affected. And most states with legal marijuana do not restrict the use around children. Another way is through just the environment. So hash oil is perceived to be more desirable than smoking the whole plant because the THC is more concentrated. In this month's Pediatrics, investigators in France conducted a national retrospective multi-center study looking at children younger than 6 who'd been admitted to a tertiary level PEDS ED for proven cannabis intoxication. Over 200 children were reported between 2004 and 2014. 71% were less than 18 months of age. Almost 3/4 of the cases were due to hashish resin ingestion. They saw a steady rise in the number of children with comas in the last 3 years of the study, and they proposed that a reason for this is the increased THC concentration in the hashish. How do you make this oil? Well, you go on YouTube and they'll tell you how to make it. You can use a butane torch to blast through the marijuana plant matter to concentrate the THC. The images I got off of the YouTube how to do this, it tells you that it's mostly safe to make it this way. The problem is that the butane, sorry, I didn't advance the slides. The butane, when it evaporates as you're doing this, is highly volatile, and all it takes is a spark of static electricity to make it explode. So these are images from the Oregon newspaper of hash oil explosions that have affected children. In one of them, a newborn was in the room. Another child, a 12-year-old girl, suffered multiple broken bones after leaping from a second floor of an apartment building from a butane explosion. This is a very similar safety issue of that home production of methamphetamine that we were having 10 or 15 years ago. Now a law in Colorado. So Colorado legislature is very busy making laws to deal with some of the consequences of their legalization of marijuana. So they enacted a law in 2015 that prohibits the use of butane or an open flame for hashish oil extraction. There's another way to do it, and you can find that on YouTube too, to make hashish oil. So, and another concern is the impaired caregiver and leading to abuse and neglect of the child. It is clear that the changing legislation and norms around marijuana use have left child welfare and public health professionals scrambling to determine best practices around issues related to parenting and child abuse and neglect for parents who use marijuana for recreational or medical purposes. So that led to the document in the middle was put together by the School of Public Health in Colorado, along with the Kempe Center for Prevention and Treatment of Child Abuse and Neglect and Children's Hospital Colorado. And this was out in November of 2016. Basically, there is no good research related to marijuana and parenting, and they call for how important it is for us to do this research. Currently in Colorado, they have no formal guidelines about how child welfare workers should handle cases where marijuana use has been recommended by a physician, even though there's concerns about child abuse and neglect, because they're legitimately using marijuana. It's resulted in several high-profile cases where allegations of abuse or neglect have been based primarily on a parent's access to medical marijuana. Child welfare is pretty stuck because a lot of their funding comes federally, and they have to follow federal guidelines in which marijuana is considered an illegal drug, and then so the parent is exposing their child to an illegal drug, but in the state, it's a legal drug. And so that would be another issue that the state of Utah would have to deal with if we pass legislation. And adolescent use. Just a few highlights about this. This map is the latest that SAMHSA put out about last month or past month marijuana use among youth. Just to point out that at that time, 2013, 2014, Utah was one of the lowest rates of states and Colorado was one of the highest rates of states. But this week's AAP meeting in Chicago, it was reported that NIDA's Monitoring the Future survey now states that past month marijuana use is now higher than the past month use of cigarettes among teenagers. So it's increasing in teenagers. Why is that? One of it, again, is the perceptions of safety. If their parents are using marijuana in the home, they are seeing that as a safe thing to do. But again, the perception of safety is that the marijuana now is much more potent, the THC content is much higher, and the latest NIDA survey showed that 70% of high school seniors said that they don't approve of regular marijuana use, but also 70% said that they didn't consider it to be harmful. There are concerns of the effect of heavy cannabis exposure on the developing nervous system of the adolescent. Because we have advances in neuroimaging, we have more and more studies that show neuroanatomic changes, metabolic and neurotransmitter activity, and neuronal activation during adolescent brain development and substance use. There's some evidence that adolescent use disrupts the normal pruning of neurons that should be occurring at this age. Also being reported that affects children is, or teenagers, is the cannabinoid hyperemesis syndrome. It was first described in 2001. It's a syndrome of cyclic vomiting associated with long-term heavy cannabis use. It seems a little paradoxical because cannabis is used to help with nausea, like related to chemotherapy, but this is heavy cannabis use. And so they present with cyclic vomiting. You find out they're a heavy cannabis user. You have them go take a hot shower. It relieves their symptomatology, but the treatment is abstinence, and then you can stop the cyclic vomiting. And then early onset use, there's a couple of studies. This recent one in March of 2017 is the early onset use has shown deficits in cognition and memory, and higher prevalence of affective and psychotic disorders. This is a really big concern of the child psychiatry professionals because of what they're seeing in these kids. And also because, again, I think of the more potent THC in the pot that's available today is transition to abuse of other drugs. There's a recent study in addiction, also by researchers at the University of Pittsburgh, used case histories, did functional MRI to assess functional connectivity in the brain's reward circuitry. The boys who started occasionally using cannabis around 15 or 16 years old and then reported that they had dramatically increased their use by the time they were 19 had the greatest dysfunction in brain reward circuitry, the highest rates of depression, and the lowest educational achievements. So this is a major concern about the availability of marijuana in states that have legalized it to the adolescent population. So in summary, The unintended consequences of increased marijuana availability include increased pediatric exposures, the majority occurring in the toddler age group, and more than half leading to emergency room visits and some hospitalizations. And as in the case with early onset of alcohol drinking, early cannabis use may have long-lasting neurodevelopmental effects on the adolescent as they move into young adulthood. These concepts, I think, are really important as our state, for us as pediatric providers, to consider as our state moves closer and closer to legalization of marijuana in some form. Thanks. We're going to move on to another topic, opioids.
Push escape. This. All right, change gears a little bit. I want to talk to you about the opioid crisis, the pediatric considerations, and the role for naloxone rescue kits in pediatric practice. I have no commercial or financial disclosures. The knowledge gap here, I feel, is that the pediatric community needs to understand the impact of the opioid crisis in Utah and then explore the role of naloxone rescue kits in saving lives. And I'd like you to develop these understandings and perhaps embrace them into your settings, into your practices, and see how you can use them. Here's the reality in Utah. Accidental overdoses are killing more Utahns than car crashes. We see click it or ticket and arrive alive and zero fatalities, all kinds of messaging encouraging us to be safer in cars. Here's what's happening in the reality. Injury deaths, preventable deaths, drug poisonings or overdoses are absolutely eclipsing firearms, motor vehicle crashes, and falls. Even to the point now that firearms and motor vehicle crashes put together, still not reaching our drug poisoning deaths. And what that's led to is that Utah has become on the forefront. 2012 to 2014 overdose death data, Utah was fourth highest in the nation. In the east, Kentucky and West Virginia. In the west, Utah and New Mexico. You ask most Utahns what states we're most like, not many people are saying West Virginia and Kentucky. In this realm, we are absolutely in the same shoes they are. 2013 to 2015 data came out, and Utah had fallen to 7th. I thought, okay, this is great. We're on a better course. Our rates still went up. It's just that other states leapfrogged over us, places like New Hampshire, places like Ohio. And sadly, I think this trend is continuing. It's happened nationwide. Here's National Vital Statistics System data from 2003 up through 2014. And these are death rates per 100,000. You can see as it went from blue to yellow to orange to red, where the zones being most impacted are. And the most recent data, 2014, we are right there in the middle of one of those red zones. Here's how it's looked county to county to county through Utah. Again, CDC data here from 2002 to 2014. The redder you get, the more impacted your county is. And a couple of counties lit up early. Carbon, Emory, down where Price is. You can see them getting red first. But the rest of the state has followed in line. To give you an idea perspective-wise, national rate is probably around 16 point something per 100,000. Utah's about 24.8 per 100,000. These counties that got red first, Carbon and Emory, their rates are 50 to 60 per 100,000. Worse than West Virginia, higher than Kentucky. Utah is absolutely in the midst of this crisis, and we're just starting to talk about it and starting to address it. What are the substances involved in these overdose deaths? Well, a lot of the data is broken out based on prescription opioid pain relievers and illicits heroin. And for me, in the ER world that I work in and in the prevention world that I work in, I honestly don't think of them a ton differently. The overdose looks the same, you treat it the same. Unfortunately, it leads to death the same way. But I do understand that there need to be different strategies based on whether or not it's a prescription substance, perhaps prescribing patterns, diversion concerns, versus illicits where it's perhaps more about interdiction and, again, prevention strategies. But to give you an idea of the trajectory our nation's been on, here's from 2001 to 2014, a pretty steady increase. Look what's happened with heroin. 2010, you can tell something happened there, right? Well, probably a couple things happened, but the major thing that happened in 2010 is that Purdue Pharmaceuticals, the makers of OxyContin, were forced to change the substrate, the stuff they pack the oxycodone in to make it be a sustained release substance. And when that substrate was changed, you could no longer or not as easily crush it out and have something you could smoke or inject or snort or use in a more fashion thought to be typicals with the illicits. And this drove a lot of people into the realm to find substances they could use the way they had been using. Sadly, it's not just that, though. You know, as we get more smart, more conservative with our opioid prescribing, the right thing to do, but the unintended consequences, there are a whole lot of people already dependent on these substances. And if it simply just becomes taking away substances without addressing the fact that people need resources for treatment, people need resources to get medication-assisted treatment, we push people this way. And if you add to that then the financial concerns, I can tell you it costs about $1 a milligram on the street to get a prescription pill, or what you assume to be a prescription pill. So an 80 milligram OxyContin is about $80 to $100 is what most people will say. You can get a little balloon of heroin for anywhere between $5 to $10 a bag. Volume discount, because this is America, right? So we are going toward this place where we're getting more conservative and smarter with prescribing, but our demand has not gone down. Our supply, therefore, continues to go up. This graphic came out in the New York Times just in the last 10 days, and it really kind of, I think, nails what's happening. So these are drugs involved in overdose deaths between 2000 and 2016 nationwide. You can see methamphetamine, cocaine, and then the top three are the opioid substances. This is based on CDC data. About 15,000 apiece for heroin and prescription opioids, and fentanyl. Oh, fentanyl has really entered the scene. We don't hear a ton about it in Utah. It's here. It's absolutely here. And it's going to continue to be here. Just for some perspective on what this is, give you an idea of what this epidemic or this crisis is doing. Peak deaths, peak injury and preventable deaths throughout kind of our last couple of decade history. Peak gun deaths in about 1993 were just less than 40,000. Peak HIV deaths in 1995 were around 44,000. Peak car crash deaths, 1972, were getting closer, above 50,000. And this was a striking figure when the New York Times released it last week. Nobody saw this coming. 64,000 people are estimated to have died in the U.S. in 2016 related to drug overdoses. 175 people a day. What does this look like more in Utah? Well, we're a little different than a lot of states. Shocking, I realize. But we have 2/3 of our deaths coming related to prescription opioids. Now, that doesn't necessarily mean that was a prescription given to you, but a prescription substance. And 1/3 of our deaths are from heroin. Most of the nation is about 50-50. Well, that means 1 death a day in Utah. Someone's planning a funeral today. Someone will be planning a funeral tomorrow. Someone will be planning a funeral after that. Picture in your head for a minute, just to give you a little exercise. And I screw this up every time. Picture in your head who that funeral's for today. Picture in your head who that's going to be for tomorrow. I picture a 22-year-old, shiftless, reckless, maybe jobless male. 2/3 of our deaths are from prescription opioids. It's me. It's 45 to 54-year-old women. That's who we're most likely to lose today and tomorrow. So these are our moms. These are our colleagues. These are our neighbors. These are the folks that truly are the most likely to be lost in Utah, at least. And when you look at heroin, it is that younger group. It is that younger male demographic. But that's only 1/3 of our deaths. And I say this because I think it's really important in pediatrics, although we are not losing the majority of our opioid overdose deaths in pediatrics. We all know and are learning more and more about trauma and how much that impacts the rest of a child's life. I will guarantee you, if you lose your mom, if you lose your brother, if you lose your whomever in your life is valuable to you as a child, the rest of your life is going to be impacted by this. For me, in the emergency department world, when I came across this data, this was probably one of the most impacting pieces for me. So this is the rate of opioid-related ED visits per 10,000. These are folks who ended up with near misses in the emergency department. Pretty striking, isn't it, to see the less than 1 year and the 1 to 4-year-old category there? These aren't kids who were experimenting or were thinking, hey, What do you think about that? These are kids who got exposed because these substances are so prevalent in our homes. There aren't pill parties happening in preschools, just in case you wondered. This is the canary in the coal mine moment for me because legitimately, and especially in Utah, if it comes in a brown bottle, it's perceived to be nice, not naughty. It's not so nice if it's ending up with your 1-year-old or your 1 to 4-year-old in the emergency department. Anecdotally, in our pediatric emergency department here, I used to be dumbfounded when I had a 4-week period where I had 4 kids under 8, just on my personal shifts in our ER, who were treated for an accidental exposure or an overdose on adult opioid medications in the home. Well, that was until I had one night, my personal shift, 4 patients, 4 years and under in the emergency department, all at the same time, 4 different homes. They all got naloxone, they all survived. But that's pretty telling of what's happening out there. And these were ways that we could all see happening. Grandpa who's on chemo and has cancer pain issues, a pill was dropped. Mom left the pills on the bedside while she went to fill her water. Mom puts the pills in the Monday, Tuesday, Wednesday, Thursday, Friday. Come on. Kids are way smarter than we are at opening stuff. And so it got me thinking a little bit, and I pulled the data from here in our facility from 2010 to 2015, and wanted to see what are we seeing. Now, admittedly, it's a skewed population, right? Because a 17-year-old heroin overdose in, say, Tooele is not going to be brought to primary children's. But I maybe expected I would see 30% of kids in that 0 to 4, 0 to 5 range. Think in your head what you would think that would be, what percentage that would be. 0 to 5-year-olds, primary children's emergency department, opioid overdose. It's 87%. That's a lot of littles and a lot of accidents that really could have been fatal, right? One pill can kill is one of the things we're taught from the very beginning of medical school and pediatrics, and it's happening. These common opiates and opioids, this is a list that you've all likely seen in some form or another, but I like to put them up just to kind of give you the perspective. To me, these are all risky substances. Had a teenager from West ask me after those unfortunate incidences with Pink in Park City, what's the most dangerous way to take this stuff? Teenage question, right? That's a perfect teenager question. And I said, well, you put it in your body. So it's got to be injecting it, right? And I said, no, you put it in your body. You could eat it, you could snort it, you could inject it, you put it in your body. Well, that kind of thinking is certainly not prevalent in our adolescents, but all of the heroin, opium, morphine, fentanyl, Dilaudid, Opanas, the Lortabs, the Percocets, the codeines, and the new synthetics that we should be frightened about, but no more frightened about than the others in my mind. Every single one of these will lead to an overdose. And I personally am advocating in my own mind, in my own practice, to ask. We ask about guns in the home. We ask about helmets. We ask about car seats. Perhaps we should be asking, are there opioids in the home? If there are, let's talk about the risks of those. The synthetic and counterfeit opioids have been getting a whole lot of sexy press, right? Everybody's very about them. And they are not going away, so I think that they deserve it. But I really want to remind people, we have a ton of these other prescriptions in the home. I think it's also very important to point out that dependence on those, what seem to be just for the moment, Lortabs or Percocets, dependence can develop in as short as 7 days. When you're writing a prescription, be cognizant of that. Be cognizant of the fact that if you are writing a prescription for longer than 7 days, that you need to talk to people about dependent symptoms. You need to talk to them about strategies for weaning down off of them. So the prescription problem has certainly contributed to this. In Utah, we write over 7,000 opioid prescriptions and fill them every single day. Healthcare providers wrote 300 million prescriptions for pain medications in 2015, which is enough for every American adult to have a bottle on them at any given time. 1 in 25 adults are receiving treatment for chronic pain with opiate pain relievers. 2+ million adults are addicted to opiate pain relievers. And as I mentioned, each day 175 people are dying from overdoses. Add to the prescription problem, the heroin problem. This report done by the CDC put out in 2015 gives you an idea of the demographics that are being impacted. And I put this up not to say, oh, now look, it looks like me that's being impacted. I put this up to say it's going up everywhere. Every sex, every race, whether or not you have resources, whether or not you have insurance. And look at our adolescents. I still think of our 18 to 25-year-old adolescent patients as my patient population. They're one of the biggest increases in demographic use. And as this use goes up, addiction goes up, and overdose deaths go up. We're losing more folks today, as that graphic showed, just to heroin overdoses than we are losing to HIV. So in response to that, the CD said, here's what I think our response should be, or here's what we think our response should be. First, we need to prevent people from starting heroin by reducing prescription opioid painkiller abuse, improve our practices, identify high-risk people early, likely some interdiction strategies and diversion prevention strategies there too. Two, we need to reduce heroin addiction by ensuring access to medication-assisted treatment. That's buprenorphine, Suboxone, methadone. And finally, reverse heroin overdoses by expanding the use of naloxone. When I started looking at naloxone, my very first talk on it was as a fellow in 2010, and I spoke to my division, and they all kind of nodded their heads like, wow, interesting. Little did I know that what seemed like an edgy topic in 2010, fast forward to 2015, I can't even be edgy anymore. The CDC is recommending that we do this. It's that much a part of this response. Finally, the synthetic and counterfeit opioid contributing component. The DEA is reporting that the most of these substances are imported from China and Mexico. And these aren't the fentanyls that we think of in patches. These are truly illicitly counterfeit produced substances. There's reports that they're being produced here locally as well as domestically. There are efforts underway to make them illegal here as well as in these foreign countries. Sadly, as we know, making things illegal doesn't make them go away, but I do think it is an important component. There's not a lot of data published on human consumption or toxicity. They're billed and sold as research substances, so we don't know a ton about them. And unfortunately, when they're put into substances that people get out there, they also don't know what they're getting. A blue pill that looks to be a 30 milligram Percocet may not be a 30 milligram anything. And hopefully it's not a 30 milligram fentanyl, but there's just no control on any of these. They found it in combination with heroin as well as in these counterfeit prescription pills. There have been some reports that higher doses of naloxone are needed, but I always think it's important to put out, especially in light of what the lay press puts out, there has been no opiate that's described or been found that is naloxone resistant or that naloxone can't get to. Certainly you might need more. So here we are in the midst of this crisis. Access to prescription opioid medications continue to be widespread. Heroin use and overdoses are increasing in Utah and the U.S. Counterfeit opioids are increasingly problematic. Overdose deaths continue to rise, and children and adolescents are impacted both directly and indirectly. What can be done? Clearly, there's a lot of things that are going to need to be done and a lot of different strategies. For me, the role for naloxone kits is what I've focused on and what I want to share with you. Our Utah State Legislature actually has done a tremendous job in empowering us to use this tool. In 2014, the first bill was passed, and I know it's a ton of words, I'll lay out the important parts for you though. The first parts of this bill said that it was not unlawful or unprofessional conduct, two things none of us want to do, right? Lose our license or break the law, to either prescribe, write it out, or dispense, hand to someone a naloxone rescue kit. And you can do this for a person who's either at increased risk of experiencing an overdose or to a family member, friend, other person, someone who's at increased risk of witnessing an overdose. Now, this is different. I can't write a prescription to Joyce to treat she thinks Karen has strep and she's just really worried about her heart and she's not sure she'll make it to the pharmacy. I can't do that. None of us can do that. But in this realm, we can absolutely provide a naloxone rescue kit to someone who we know they'll use on someone else. Absolutely legal to do so in this state. It's very clear that no physician-patient relationship is required. So again, a parent that is not my patient or not any of your patients, you can equip them. It does require that a person who prescribes or dispenses opiate antagonist medications, you got to tell folks they need medical evaluation. They have to call 911. They have to get that person to an ER. It's not just a standalone do this at home. And finally, clarifies that the administration of naloxone is voluntary. Just because you have it does not mean that you're going to be expected to use it. It is your choice. There's no increased liability for someone having naloxone in their possession. But we realized after this bill was passed that just having pharmacies have naloxone and physicians write naloxone abilities wasn't going to get it into people's hands. The typical model of, boy, we want people to get vaccines, so we'll put them in health departments and pharmacies and clinics, and that means people will get them, didn't apply with naloxone kits. We had to be able to get it into hands other ways. So in 2016, legislation went back and said, all right, we're going to create an overdose outreach provider, an OOPS. And they are law enforcement, fire departments, EMS providers, a whole list there of all the people you might expect, right? People that work in rehabilitation, people that work with those experiencing homelessness. And we thought this was pretty smart, all the way down to individuals. Any individual in the state of Utah can function as an overdose outreach provider and take a naloxone kit and put it in the hands of someone else, even though it's a prescription substance. This is how we can get it out into the hands of the most people, because folks sometimes won't talk to their doc about things that they think to be unhealthy, unwise, illegal. They might not talk to their pharmacist if they live in Castledale and there's only one pharmacy, and they know the pharmacist, and they know the person ringing up their prescription, and they know the 3 people behind them. They may not do it in that route, but they'll certainly talk to a mom who has another heroin addict as well and understands their struggle and will allow them to be equipped. Naloxone kits come in a bunch of forms, 4 different, 2 generic, 1 intranasal and 1 injectable, 2 brand. There's a whole nother lecture involved in this. Talk to me anytime if you want to hear about what they are. You can find information on the web or on our website. They are a variety of costs, as you might imagine. The generic injectable is the least expensive, down to about $40. The product that's an intranasal that you just pull out of the package, push in the nose, is around $150. There is a commercial auto-injector that's available, but the wholesale price is over $4,500. That's at our pharmacy here. I had them check most recently. Most insurance plans, including Medicaid, do cover the costs of these kits, and there are free kits available from the Department of Pediatrics program and additional agencies throughout the state. These kits can be stocked in a variety of places. All Intermountain Healthcare outpatient pharmacies have them with no prescription needed. University of Utah Healthcare retail pharmacies have them. Chain pharmacies, VAs have them. Here in Salt Lake City at the Apothecary shop, we do have free kits available, as well as at Salt Lake City Fire Department, where folks can walk in and ask for a free kit, one of our kits, and they'll get them. There are several associated food stores and CVS stores and others that, using a standing order put through by the legislators, that they can get there too. Sadly, having it available in a pharmacy isn't always enough, but sometimes folks will use it. There are pharmacy lists and prescriptions available on the web. So knowing that this is out there, planting into your head, who is at risk in my setting? Who should I be thinking about talking about this with? Well, it's a long list, but they're not unexpected, folks. People who have a history or vulnerability for substance abuse, people who have prescribed high-dose opioids in the home. I've been absolutely amazed how many people I can talk to about their opioids. One gentleman recently was 60 milligrams of morphine 6 times a day. I was afraid if he breathed on me that could be a pretty high dose, but he said, I take as prescribed, I'm gonna be just fine. And I thought, okay, he's not gonna hear that argument. Do you have kids in your home? Oh, yes, I do. Do you know that one of those pills could absolutely lead to a potentially fatal overdose in your child? Can we get you equipped just in case? Oh, yeah, that's a great idea. By the way, sir, it's also available to be used on you. 1 kit, 1 home, any of you. But using that pediatric angle is really a way a lot of times we can protect the entire family. Those with a current or history of psychiatric illness, those with benzodiazepines and opioids in their possession, both. People who have a history of misusing medications, taking more than prescribed or drinking alcohol with their medications. People who've had an overdose before or currently in an emergency department for an overdose. People with comorbidities. Veterans. Utah has the #1 rate of death in veterans from overdose in the nation. And finally, this big one, after release from a period of sobriety. So after a release from prison or treatment or supervised care or hospitalization for having a baby, a time when folks have done right by themselves and gotten well, and unfortunately go back and have a misstep and use again. This is when we are most likely to use them, when tolerance is down and they don't realize it, and for a lot of reasons don't tell someone. So just to give you an idea, and hopefully not sounding as if though I'm trying to toot any horns, this can make a difference if you talk to folks about it. Utah Naloxone was launched in July of 2015 here in the Department of Pediatrics. Over 10,500 free Naloxone kits have been distributed. 1,760 3, I actually heard of another one this morning. Overdose reversals have been reported, both amazing and frightening to me. These reversals have been reported by parents, by spouses, by friends, by law enforcement, by strangers, by a 14-year-old who rescued her mom in the last couple of weeks. 54 law enforcement agencies have been equipped and trained statewide. They're saving lives. In some of the agencies, they save lives within 24 hours. There's 129 law enforcement reversals in the first 16 months. We've been able to launch a program with Salt Lake City Fire where when they respond to an overdose, a lot of times they can release someone on scene from a heroin overdose. They don't get that opportunity to talk to an ER doc or to get another intervention. Salt Lake City Fire is leaving kits on the scene with their families and their friends, those around them. We've trained in over 270 settings, been involved in passage of legislation, and have launched a statewide awareness and billboard campaign, all with the hope that more people will talk about this, think about this. Naloxone is not going to stop this crisis, but it's going to keep people alive while we get on top of better treatment strategies, better prevention strategies. We got into this work because in 1996, we lost our brother Andy to a heroin overdose. If you've seen our billboards, you've now met Andy, if you haven't met him in another way. And truly our hope with these efforts is that by educating and equipping people, there will be less Andys. Thank you.
You got me all teary right before I had to stand up. Questions? Up. I'm running.
Oh, we're supposed to stand.
So Jen, you definitely deserve to toot your own horn. Incredible effort. But you didn't have time to touch on the treatment side. And
Yeah.
we're ahead of the curve in naloxone treatment. We're behind the curve in access to Suboxone and other medically assisted treatment. Can you talk about that for just a second?
Yeah, and it's a challenge, right? So medication-assisted treatment, opioid replacement treatment, there are not enough providers. There's not enough access. There are very few, from my understanding, pediatric and adolescent-specific providers in the state. I think that if there were a way for us to explore that and to get people on opioid replacement treatment, it's essentially folks are dependent on an opioid. There's something in their brain that craves that, tells them that they need that. If you fill that neurotransmitter with another opioid substance in a much safer way, you give them an opportunity to get their life back on track, to stay in school, to keep their job, to not lose their family. I personally think you're exactly hitting onto it. We have got to advance that. It's a challenge, though. Funding is tough, insurance coverage can be tough, and stigma in this state is very tough. There's a lot of folks who only believe in abstinence-only treatment, and I know of several whose lives are really in great places because of it. I'm open to anyone's ideas on how to make that happen.
I just wanted to thank you for this. It's given me some great ideas. I've been doing a palliative care fellowship that includes working up at the Huntsman Cancer Center with their pain specialists, and I've written more opioid prescriptions in that short time than I could imagine, but in a controlled setting where we doppel every patient and that sort of thing. But I'm realizing that this should be part of our discussion.
Yeah.
Everybody writes about talks about when you write for an opioid, you write for Senna, et cetera. But I'm like, maybe we should be writing for naloxone as well. But I did have a question if there's any discussion about, this came from my own experience and then other people. I had knee surgery. They gave me 20 Percocet 5. I used 3 and it was on me to take them back and dump them in, at a pharmacy or in a receptacle. I've had somebody, and I'm not kidding, walk in with a bag full of pills, multiple, like OxyContin, and just high-dose opioids that he says, I kept getting prescribed these for my pain. I don't like taking them. They don't feel good. But nobody ever wants them back. So they sit in his house until he walks in with them, or they just sit in his house until somebody else gets them. And I was just wondering if there's ever talk of incentivizing returning unused opioids as a tiny piece in all of this.
That's a great point, too. The Use Only as Directed campaign has been out trying to encourage people's safe disposal. Here, downstairs at Primary Children's, we have the blue bins. University of Utah Health Centers all have them as well. They look like big old mailboxes, kind of. Incentivizing it, though, that's interesting. Like, if there a way, if you bring this back, you will blank. That's a great idea. People love gift cards for certain.
Yeah. And another approach at the University of Utah, that the work that we're doing on the task force, is that, for instance, surgery is involving residents in this about how much do you really need to give someone who just had an appendectomy? And they're seriously looking at, because in a lot of situations in our teaching institution, it's the frontline interns and residents that are writing the pain meds. But with involving the residents in the project as a quality improvement project, they are reducing the number of of pain meds you even dispense. So that, and changing the discussion about the expectation of what pain relief really is for some of these. So it has to start from the very beginning. We're also actively working at the university with introducing the concept of ESPERT, where everybody screens for the potential of abuse when they're working with someone before they prescribe opioids, if they already have a substance abuse problem. But this is going to be multifactorial approach to decrease the amount that we're prescribing.
Can I just please take the opportunity just to do a little PR announcement on our Utah opioid course that we just rolled out, actually involving many people, Jen and Karen. With about the help of 10 faculty at the University of Utah, we actually just rolled out the Utah opioid course. For your 2018 DOPL licensing renewal, you are required to take 3.5 hours of opioid education. So this course will satisfy that 3.5 hours. In fact, we have 6.5 hours of education if you so choose to take all 6.5 hours. And it satisfies DOPL licensing requirement. You can get CME credits, and for the Board of Pediatrics, you can get MOC credits as well. So it actually satisfies 3 ways of getting credits for what you need to do in an up to 6.5 hours of education.
And it does have a pediatric focus, which is nice.
Yes,
The
so
previous DOPL courses have not had pediatric-specific bits, and
Yes.
on this one, which I think is great.
So out of the 3 courses that DOPL has approved, ours is the only one with OB and pediatric focus, in addition to adult medicine. So hopefully this is more applicable to our practice. And it is for a charge of $49.95. Trainees do get a reduced price. And you have to take one of the 3 that's approved by DOPL. So I would just urge and encourage you to please consider ours, because it took a lot of people's efforts to put this together. And we had it professionally videotaped this time. You can pause, unlike the last version. You do have to take a test because that's DOPL's requirement. And hopefully it's a lot more user-friendly than the last version. Thank you.
Thank you. And I agree, as I run over to the other side, we're going to have to take just one last question. But educating the residents, I had one the other day in the ER who wanted to give like 20 oxycodone to a 4-year-old with a penile contusion from a toilet seat. And I said, have you ever been in our emergency department before?
Yeah.
My question
Yeah,
is just on training for acute care, mostly with the naloxone kits.
Mm-hmm.
Do we have PALS scenarios? Are we really making it a priority in PALS? Are we doing this in the sim lab, where it just becomes rote for people? Grab the kit and give it instead of any hesitation. I know it seems pretty simple,
Mm-hmm.
but it would be great if every healthcare worker had that ability.
Had that
to just
mindset that
grab
that
it
was
if they
going
can
in,
carry that.
right? And like we
But
think of
use it
staying
in
alive, as soon as you
well.
say PALS, I think staying alive. That if it went right to that, I know it's in the AHA guidelines, naloxone now is for resuscitation, but that's a great point. Well, I'll follow up and circle back with them. That would be a good spot to have it. Yeah,
Sadly, we're going to have to take the rest of the questions offline.
Yes.
Thank you.
yes, thank you all. Thank you.
You did wonderfully, my dear. It was so